уже несколько лет. Это лекция профессора Ванденпласа, которая состоится сейчас вот во время этого симпозиума в этом зале. Поэтому просим всех садиться, и мы начинаем нашу работу. Я думаю, что многие из вас читали различные статьи, гайдлайнс, и в том числе официальной позиции Европейского общества нутрициологов, гастроэнтерологов, так называемый СГАН. Но мало из вас, кто представлял, что сможет иметь эту уникальную возможность услышать авторов большинства из них вот так живьем во время нашего конгресса. Поэтому мы очень благодарны профессору Ванденпласу за то, что он приехал и, соответственно, участвует в нашем конгрессе педиатров России. У нас программа очень такая понятная, короткое мое выступление. Я просто буквально в нескольких слайдах хотела бы изложить позицию наших отечественных педиатров на функциональные нарушения пищеварения у младенцев. И затем будет большая подробная лекция моего сопредседателя, который, собственно, и расставит все точки над «и». Поэтому, если вы не возражаете, мы начинаем сразу. Спасибо. Нет, тут стоит презентация его. Ну ладно, хорошо. Этот доклад подготовлен в соавторстве с нашими ведущими неонатологами. Но вы знаете, что дисфункция желудочно-кишечного тракта, к сожалению, возникает практически у всех детей раннего возраста. В общем-то, кто-то считает их даже условно-физиологическими. Но действительно, если они возникают практически у всех, наверное, они нормальные. Тем не менее, это непременные условия периода адаптации, созревания желудочно-кишечного тракта новорожденного и грудного ребенка. Хочется подчеркнуть, что в нашем понимании все-таки функциональными нарушениями мы называем именно к функциональным относятся именно те нарушения, в основе которых лежат действительно очень такие ограниченные изменения. Все, что связано с тяжелой органической патологией, безусловно, не может называться функциональными нарушениями. Клинически они могут проявляться по-разному. Наиболее, так сказать, на поверхности лежат и хорошо всем известны такие симптомы, такие проявления, как срыгивание, рвоты, колики, диареи, запоры. Общее беспокойство ребенка, которое, вы знаете, является практически проявлением любой болезни, начиная от очень серьезных и заканчивая действительно временными такими изменениями. Нарушение аппетита, метеоризм, интоксикация и как более грозное проявление эксикоз, нарушение нутритивного статуса и так далее. В общем-то, позиция отечественных неонатологов заключается в том, что в 10% примерно это вообще, в принципе, в основе многих функциональных изменений лежат все-таки вегетовисцеральные изменения, церебральная ишемия. И вот здесь естественно, закономерность, которая, опять же, лежит на поверхности. Чем больше проблем у новорожденного, степень незрелости, преждевременность появления на свет, тем, естественно, выраженность этих проявлений выше. В частности, по данным НЦЗД, вы видите, если для доношенных новорожденных это примерно 75%, то для недоношенных цифра возрастает уже практически до 87%. Вегетовисцеральное нарушение – это широкий спектр морфологических, функциональных сдвигов в разных органах и системах, и, соответственно, они обозначаются как соматоневрологические, нейросоматические или нейроэндокринные. Конечно, преимущественно имеется в виду желудочно-кишечные, сосудистые нарушения, иногда также и нарушение терморегуляции. В остром периоде церебральной ишемии основными клиническими проявлениями вегетовисцерального синдрома новорожденных являются те или иные дисрегуляции сфинктеров ЖКТ, что вызывает соответствующие клинические проявления, как зияние, так и спазм, и дискинезия желудочно-кишечного тракта, отсюда проявления такие, как диарея или запоры. Как уже было сказано ранее, часто это все сочетается с нарушениями терморегуляции, сосудистого тонуса и дыхания. Ну а, соответственно, ведущим звеном формирования вегетовисцеральных нарушений является поражение таких структур мозга, которые перечислены на слайде. Как правило, при выраженных вегетовисцеральных нарушениях эти изменения со стороны желудочного и кишечного тракта достаточно быстро из категории функциональных переходят в более серьезные, поскольку наслаиваются такие проявления, как вторичная ферментативная недостаточность, нарушение микробиома, нарушение всасывания, в целом расстройство питания. Вот про нормальное заселение, соответственно, и появление нормального микробиома. Здесь, знаете, в последние годы, конечно, тоже очень пристальное внимание. В частности, в серии лабораторных исследований на мышах было показано, что напрямую зависит степень выраженности и частота проявления аллергических различных поражений с тем, насколько своевременно и адекватно идет заселение кишечника. И, к сожалению, в большинстве случаев эти проявления очень быстро становятся необратимыми, несмотря на потрясающую высокую пластичность организма новорожденного ребенка. Последние работы свидетельствуют о том, что даже пораженные фибробласты сердца у ребенка до 7-дневного возраста, то есть на первой неделе, еще способны к полному восстановлению, чего никогда невозможно представить для ситуации со взрослыми. Ну, про факторы риска нарушения формирования нормального микробного пейзажа все вы хорошо знаете. Единственное, еще раз хочется подчеркнуть, как много зависит от того, насколько правильно ребенок появился на свет соответственно, с применением оперативного вмешательства или естественным путем, насколько правильно он пребывает совместно с матерью или изолированно. То есть те современные технологии ведения детей в период новорожденности, они тоже очень большой накладывают отпечаток, так же, как и такие хорошо известные факторы, как раннее искусственное вскармливание. Ну и, соответственно, совершенно понятная группа риска нарушения формирования нормальной микробиоты у детей первого года жизни. Это дети с различной патологией, недоношенные и рано прервавшие или не имевшие естественного вскармливания. Есть ли у нас возможности влиять на это? Безусловно, есть. Я на них останавливаться не буду. Два очень коротких примера. В проведенной нами серии работ по введению одной из линеек прикорма было показано, что при правильном выстраивании этой схемы вы видите, как функциональные нарушения достаточно быстро сходят на нет. То есть это говорит о том, что потрясающие резервы заложены у нас в правильной организации вскармливания младенца. И еще недооцененная роль такого фактора, как правильные соски или другие девайсы, которые позволяют нам в ситуации с искусственным вскармливанием также бороться с некоторыми функциональными нарушениями. К чему я это говорю? Конечно, очень привлекательным кажется применение большого количества лекарственных средств, которые на сегодняшний день могут как будто бы помочь справиться с различными клиническими ситуациями. И вроде бы они и такие достаточно безвредные, и те же антациды, и ингибиторы, блокаторы протонной помпы. Но ведь не надо забывать, что мы имеем дело с детьми новорожденными, у которых еще вся жизнь впереди. И вот здесь особенно осторожными нужно быть в назначении лекарственных препаратов. Поэтому наша позиция отечественных педиатров, конечно, это прежде всего помощь наших коллег-нутрициологов, которые должны помочь нам выстроить правильно, рациональное вскармливание новорожденного ребенка. Это правильные рационы, которые сопровождаются и правильной организацией в целом жизни всей семьи, и матери, и новорожденного, и только как вторая линия возможность обсуждения тех или иных лекарственных препаратов. Об этом, я думаю, более подробно расскажет нам профессор Ванденплас. Благодарю вас за внимание.
Good afternoon, everyone. After this very beautiful introduction, it is my time to thank you for the invitation to visit Moscow and to thank Abbott Nutrition to have brought me to this beautiful city. I always enjoy to visit your city. The topic I was given to discuss with you is about frequent gastrointestinal disorders in infants. And in fact, what I would like to discuss is a paper that was published beginning of last year, which is a consensus paper with authors from worldwide, from Latin America, North America, Europe, Asia, a broad consensus on how to deal with frequent gastrointestinal disorders in infants. The best way how to feed infants is, of course, with breastfeeding. And I will say only very few words about breastfeeding, but it's obviously that that is the recommended way to feed all infants, wherever, how big or small the breast is or where it's located. As you can see on this slide, breastfeeding is the best way how to feed infants. The different topics that we will cover is regurgitation, cow's milk allergy, colic, crying infants, constipation, and then we will come to conclusion. Gastrointestinal manifestations in infants are a complex physiopathogenic mechanism that usually occur within the first weeks of life, and they are generally associated to feeding and more associated to infant formula than to breastfeeding. According to different healthcare professional reports, the prevalence of these problems is very high. It's about 20–25% of all infants, and I will show you later figures which are even higher. The problem with this kind of presentations is that we separate each topic from each other: the crying baby, the constipated infant, the baby with gastroesophageal reflux. But in daily reality, there is often a mixture of these symptoms because they all influence each other. For instance, if you have babies with regurgitation, because of the regurgitation, they can cry a lot. Because they cry a lot, they swallow a lot of air, so they get also gassiness and fuzziness, and then they get stool problems. So in daily reality, gastrointestinal symptoms in infants is a mixture, and it's up to the physician to try to discover which was the starting point of the complex symptoms that these infants often present. The next slide shows you the prevalence which is reported at least once during the first 6 months of life worldwide. So this is the incidence of infants that are presented to a doctor because of gastrointestinal discomfort. And you see that it's, in fact, worldwide quite stable. Worldwide, this incidence is about 50% of all infants. So one baby in two is presented to a doctor because of symptoms of gastrointestinal discomfort, constipation, crying, regurgitation, whatever. But 1 in 2 is a tremendous high prevalence, of course. And that's why this is a topic that occupies us pediatricians so much, because it's really something with which we have to deal every day. And the other point is that evidence-based studies in these frequent gastrointestinal problems are very limited, because it's quite difficult to perform well-randomized, double-blind, controlled trials in those frequent gastrointestinal complaints. That's why consensus is a step forward, because up to now, most of the guidelines are individual-based. This study shows you also data about the prevalence of gastrointestinal complaints in northern Italy. And so it's a study in 150 general pediatricians, who each of them followed the next 20 babies coming to their private practice to look at the frequency of gastrointestinal symptoms. And you will see again that it's 50% of all the babies who do have gastrointestinal complaints. So the same incidence as I reported on the previous slides. And you see that's about 20% of the babies with regurgitation, 20% with colic, 20% with constipation. And of course, if you add all these figures together, you end up with an incidence which is much higher than the 50%, what confirms what I previously said, that many of those babies present to you with a mixture of different of those manifestations. Are these problems worldwide the same incidence? Again, I would like to come back to this topic and show to you that indeed, yes, it is. This slide looks at the prevalence of regurgitation, and these are data from Susan Nelson, from Chicago, so from North America. And it shows you that in 4 to 6 months old babies, so 4-month-old babies, more than 50% regurgitate at least once a day, and that 20% regurgitates more than 4 times a day, and that about 20% of the mothers regard that regurgitation as a problem. So about 20% of the mothers consult a pediatrician because their baby regurgitates, and you could say, conclude from this, that more or less 4 episodes of regurgitation a day is a reason for the mothers to be concerned and to go to consult a doctor. And then we looked for these data also in Jakarta, Indonesia. So in a totally different population, I had a colleague who looked at the frequency of daily regurgitation. And what you see is that in 3-month-old infants, so the same from Chicago, about 50% of the babies do regurgitate at least once a day, and that exactly also 20% of the infants do regurgitate more than 4 times a day, and that if you ask the mothers if that is of concern, it's exactly also 20% of the mothers which regard that regurgitation as a concern. So whatever part of the world you're looking at for regurgitation, it's more than 4 episodes a day, and it's 20% of the mothers who seek medical help because of that frequent regurgitation. And if that's true for regurgitation, there is no reason why it should not be true for the other symptoms. So frequent gastrointestinal complaints are at the same incidence worldwide. So let's focus now on regurgitation. And as you can see, it's not only babies who regurgitate, but pumpkins also have this kind of problem. Regurgitation is mainly a problem of the first 6 months of life. This slide shows you the data on the natural history of the evolution of regurgitation. And although the number of babies that regurgitate daily differs from study to study, it's obvious that during the first 6 months of life, this problem is much more frequent than during the second period between 6 and 12 months of life. So what did we say in our guidelines from the North American and European Society of Pediatric Gastroenterology? We said that a history and physical examination with attention to warning signs is sufficient to establish the diagnosis of uncomplicated reflux, which is regurgitation. And what do you need to do is reassure the parents. Parental education, reassurance, and anticipatory guidance are recommended. And in formula-fed infants, thickened formula, anti-regurgitation formula by preference, reduces the frequency of overt regurgitation and vomiting. In other words, anti-regurgitation formula is recommended in those babies that present to you with frequent regurgitation. So the best thing that you can do in regurgitating infants to reassure the parents is give them an effective treatment, and so anti-regurgitation formula has definitely its place there. So how should we manage those infants with frequent gastrointestinal problems? And the guideline I'm going to present you is a further evolution from the algorithm which was published in the 2013 paper. So what did we say? We say that if the baby presents with more than 4 episodes of regurgitation a day, because that's clearly the incidence which makes parents anxious, since at least 2 weeks, because you don't want to treat every baby who just regurgitates for 2 days. And if the age of onset is above the age of 3 weeks and before the age of 6 months, then you should consider regurgitation. So if that's not the case, then you have to consider other etiologies. For instance, if the baby is only 1 week old, then the likelihood to have anatomical abnormalities is much higher than if the baby is more than 3 weeks old. So the condition is more than 3 weeks old, less than 6 months old, regurgitating more than 4 times a day since more than 2 weeks. If that's the case, you evaluate and correct the way the baby is fed. You look at the feeding frequency, the volume, and at the way how the parents feed the baby. If that's not normal, you correct it and you let them come back to see if that did help. At the same time, you look if there are alarm signs, and these alarm signs are vomiting, irritability, crying, fuzziness, arching back, Sandifer syndrome, coughing fits, and the most important one, I think, which is relatively rare but very important, is failure to thrive. If these alarm signs are not present, then it's probably physiologic regurgitation. You treat the baby with anti-regurgitation formula, you reassure the parents, and you'll follow the child at the Well Baby Clinic. If there are alarm signs, then you should consider cow's milk protein allergy, because I will come back to that later to that, but vomiting babies, vomiting may be a symptom of cow's milk protein allergy. And so then you should, if those alarm symptoms are present, consider a trial with an extensive hydrolysate, which you can thicken or not. It does not really matter. Then you look if there is improvement. If there is improvement, you challenge. I will come back to that if we are in the algorithm for cow's milk protein allergy, and you follow the child. If there is no improvement, you should consider real reflux disease, eosinophilic esophagitis, or anatomical abnormalities, and otherwise you need to refer then the patient to a specialist. So with this algorithm, This is the recommended algorithm to treat frequent regurgitation and to try to reassure parents what is very important also with dietary treatment, which is effective and which has no side effects, and not using drugs or medication at all. So the next topic is then cow's milk allergy. The problem with the diagnosis of cow's milk allergy is that there is not one specific manifestation, and that you can have skin manifestations, gastrointestinal manifestations, general symptoms, systematic reaction, and also respiratory symptoms. So there is not one pathognomonic symptoms for cow's milk protein allergy. We have to be aware of that. Any of the symptoms can be caused by other diseases. What can help us is that 90% of the children with cow's milk allergy will develop symptoms before the age of 3 months, or at least within the 2 months after the introduction of cow's milk in their diet. And cow's milk allergy rarely develops after the age of 1 year. What is cow's milk allergy? Well, it's defined as a reproducible clinical abnormal reaction to cow's milk protein due to the interaction between one or more milk proteins and one or more immune mechanisms. And that's a very nice definition, but in daily practice, we are not much helped with this, because except for the IgE-mediated reaction, we have no way to show that the immune system is really involved. So it's a nice definition, but in daily practice, pediatricians are not really helped with this definition. Because if you look at the guidelines also, do you have to do IgE testing? Do you have to do skin prick testing? It's always left over to the physician to decide yes or no, because it's so different from country to country. And it's true, it helps if it's positive, but it's false negative in a lot of cow's milk allergic children. And the diagnosis is a challenge, but do you have to do that challenge open? Do you have to do that challenge double-blind? Most of the countries, most of the situations, parents just refuse to do the challenge. The general recommendation is to do an open challenge, but we know from studies from the Netherlands that if you do a double-blind challenge, that you reduce the diagnosis of cow's milk allergy with about 30%. So another problem is that our golden standard is a challenge test to diagnose cow's milk protein allergy, but a challenge test does of course not prove at all that your immune system is involved. If you would do a challenge test with a child which has a lactose intolerance, your challenge test will be positive as well, because most of the dietary treatment formulas for cow's milk allergy are lactose-free. So yes, it's our golden standard, but it has a lot of drawbacks. So when is the suspicion of cow's milk protein allergy stronger? As I said already, when symptoms develop within 2 months after introduction of cow's milk, symptoms develop within 2 hours after the ingestion, if more than one organ system is involved, if you have a combination of gastrointestinal and respiratory tract, for instance, if you have a family history of atopy. This is the practical diagnostic guideline which was recommended by the ESBGAN guidelines published in 2012, and it says to you that if you suspect cow's milk protein allergy, you should do a diagnostic elimination test of about 2 weeks. If then there is no improvement at all, then the likelihood of cow's milk allergy is relatively low. If there is improvement, then you should challenge with cow's milk protein again, and if that challenge is negative, there is no cow's milk allergy. If the challenge is positive, it's likely to have cow's milk protein allergy. When do you have not to challenge? It's when you have anaphylactic reactions and in combination with high specific IgE, then a challenge test is not necessary to perform. What's about the natural evolution of cosmic protein allergy? Well, most of the children will get tolerant to cosmic protein. And according to the data, which mainly come from tertiary care centra, it's about 50% of the children which are tolerant at the age of 1 year, 70% at 2 years, up to 90% at 3 years. My personal conviction is that the incidence of tolerance at the age of 1 year is much higher than the reported 50%, but what we are missing are data from primary healthcare. All these data come from specialized centers who see the most severe patients, and therefore they do not really represent the real natural evolution. I think that the vast majority of challenge tests are done by coincidence, by grandmothers who give a biscuit with some cosmic protein at the baby, and then nothing happens. And so I think that up to 80–90% of the infants are tolerant by the age of 1 year. What we know now is that IgE-mediated cow's milk allergy has an increased risk of persistent manifestation, and that IgE-mediated cow's milk protein has an increased risk of developing allergy to other foods. So what about our guideline for the treatment of cow's milk allergy? You see a child which is suspected to have cow's milk allergy. If it's a breastfed baby, you have 3 groups: the breastfed baby, the formula-fed baby with anaphylaxis, which is very rare, and anaphylaxis was never reported in breastfed babies, and then you have the formula-fed baby with other manifestations. Going back to the breastfed baby, what you have to do? You continue the breastfeeding, you put the mother on an elimination diet, and then you see what happens. There is improvement or not. There is no improvement, then you should record compliance, and then it's probably not cow's milk protein allergy. If there is improvement, you should consider to challenge and to reintroduce cow's milk protein in the diet of the mother and see what happens. If the baby is anaphylactic, has an anaphylactic manifestation, then the idea is, let's treat with the best. Let's give this baby immediately amino acid-based formula for 2 to 4 weeks. Do the symptoms improve or not? If they do not improve, then it's not cow's milk protein allergy. If they improve, then you should again challenge that baby, except if it's really anaphylactic reaction, as I said, then it's not recommended to challenge, because your challenge may be life-threatening. For the vast majority of our formula-fed infants, they will present with other manifestations. You give them an extensive hydrolysate formula for 2 to 4 weeks, or soy, or an extensive rice hydrolysate formula if the extensive cow's milk-based hydrolysate is not available, if the baby does not want to drink it. So soy and rice hydrolysates are second choice options. Cow's milk-based extensive hydrolysates are the first option in the treatment of those infants suspected of cow's milk allergy. And then again, you see if there are improvement of symptoms or not. If there is no improvement of symptoms, then it's probably not cow's milk allergy, although you should be aware that about 2 to 4% of the infants with cow's milk allergy may still react allergic to the extensive hydrolysate. So if you suspect that, then you should put those babies on an amino acid-based formula for 2 weeks again and see what happens. If there is improvement, you challenge the child after your 2 to 4 weeks of elimination diets, and you see if symptoms relapse or not. If symptoms relapse, what is your long-term follow-up? Well, it's elimination of cow's milk in the breastfed babies, a longer diet with the extensive hydrolysate formula, and eventually your soy or rice hydrolysate as second choice option if the extensive cow's milk protein hydrolysate is not available, if the baby refuses to drink it. And then you monitor for follow-up, you should give this elimination diets for at least 6 months or up to the age of 1 year. This brings us to the next topic, which is the crying baby. And in literature, there is a lot of confusion because a lot of pediatricians think that a crying baby must have occult gastroesophageal reflux. And it's true that in our guidelines, we say that infant irritability, crying are manifestations of gastroesophageal reflux. However, we do not mention how frequently this occurs, and we certainly do not mention that this occurs in babies who present without symptoms of regurgitation of vomiting. And I think that crying, a single manifestation of gastroesophageal reflux, is really very rare. The same is true for our ESPGHAN, NASPGHAN guidelines, where we also say that irritability in infants is one of the manifestations of gastroesophageal reflux disease, but we never say that it is the only manifestation. So we certainly do not provide data on how frequent or how specific this is. And I think that the concept that infant irritability and sleep abnormalities are as manifestations of gastroesophageal reflux, that's largely extrapolated from adult descriptions of heartburn and sleep disturbances that improve with antacid therapy. We, as adults, we feel heartburn, we take an antacid, and the pain disappears. So we think that crying babies may have heartburn also, and therefore we treat them with antacids. What does the literature tell us? The literature tells us that proton pump inhibitors are in fact somehow effective. This is a study from Susan Orenstein, where the endpoint was of this clinical trial that there should be a reduction with more than 50% of the crying time. So the proton pump inhibitor was considered effective if crying time was reduced by more than 50%. And what do you see? That with the lansoprazole, so with the proton pump inhibitor, indeed 54% of the babies cried less. But the efficacy was exactly the same in the placebo group. Also 54% of the babies cried less than 50% of the time with the placebo. So no difference between proton pump inhibitor and placebo. What was the difference? The difference in adverse effect. You had much more gastrointestinal and respiratory tract infections in the babies on the proton pump inhibitor than in the babies on the placebo. Several studies have been performed afterwards. This is a review from 2 years ago from all publications that had been reviewed by the FDA for 4 different proton pump inhibitors, all the time coming to the same conclusion: all studies are negative. Last year there was a study published from Australia group on symptoms in newborns thought to be related to acid reflux. The result was again completely negative. And there is more and more literature that proton pump inhibitors do have important side effects. About 20-25% of the children and adults develop bacterial overgrowth. And we are so busy with healthy gastrointestinal flora development and putting prebiotics and probiotics in infant formula, but then we are going to disturb that gastrointestinal flora by giving them proton pump inhibitors. And there is a lot of evidence also that you had more infectious diseases in children on proton pump inhibitors. And the first clinical trials are published that you get more food allergy in patients on proton pump inhibitors. Yet, what do? These are data from 2010. You see that proton pump inhibitor and H2 blockers are at the number 12 and 8 position of the most prescribed medication in the US in children under the age of 2 years. In Belgium, 20% of all the babies under the age of 1 year get at least one prescription of antacid medication, while the evidence from the literature is that it does not help. So what is our recommendation for our baby with colic? Certainly not to give proton pump inhibitors. What do we say? Well, if the baby is less than 3 months of age, if there is fuzziness, irritability, frequent crying for more than 3 hours a day, since more than 3 days a week, and at least for 1 week, then we see if there are red flags for organic disease, and they are more or less the same. It's frequent regurgitation, vomiting, cough episodes, Sandifer position, family history of atopy, respiratory dermatological atopy symptoms, gastrointestinal bleeding, failure to thrive, abdominal distension with meteorism, with or without diaper rash. And at the same time, you looked at the presence of red flags for the psychological aspects, evaluation of the anxiety of the parents, parental depression, look at mother-child interaction, and risk for child abuse. If that's the case, you should consider hospitalization and observation. If that's not the case, you should support the mother, the parents, and the only evidence that there is from literature is that extensive hydrolysates or a cow's milk-free diet in the breastfed baby may be beneficial here. Now let's move to the organic part again. If those red flags are present and there are alarm symptoms, you should absolutely refer the child to a specialist to have further investigations. If these are not present, then you should do again the same as if there are no risk factors for the psychological part, support the parents, try elimination diet and see what happens. If there is improvement, yes or no. If there is no improvement, you again should consider hospitalization for observation. If there is improvement, you maintain support and you go again to the algorithm for the cow's milk protein allergy. So let's then move to the next baby, which is the one which has more problems with crying and fuzziness. The same kind of algorithm, excessive crying, gauze, and fuzziness. You look if the baby is breastfed or formula fed. You look for the presence of red flags, which are exactly the same as in the previous slide. Those red flags are present. You should, of course, refer the patients to a specialist. Those red flags are not present. And if the patient has also diaper rash, then there is likely acid stools or diarrhea, post-gastroenteritis, or there are reducing substances in the stools. You look at that. If that's not the case, you educate and reassure the parents. If that's the case, if the baby is breastfed, you should not change the diet. If the baby is formula fed, you can reduce the lactose or get a lactose-free formula for a couple of weeks. Does that bring improvement or not? If it brings improvement, you discharge and you follow the child. If there is no improvement, you refer the patient to a specialist. So that's the recommendation for the baby with gassiness and crying. Then we move to the next topic, which is constipation, which, as you can see, is also an old problem because Flemish classic painters already made paintings with infants with this kind of problem, recommending clearly rectal treatment. Let's see if we still do that today. As I said, for regurgitation, mothers are concerned of what comes out of this baby, of their babies. This is also true for stools. So this looks at formula-fed baby versus breastfed babies, and you see that sometimes concerned, it's 40% of the mothers who are giving formula to hardly ever occurs in breastfed babies. So what's our algorithm for constipation in infants under the age of 1 year? Well, we start with a definition, which is difficult or rare defecation for at least 2 weeks. And of course, the incidence of rare defecation differs for formula-fed or breastfed babies, where it's less than 1 stool per 3 days in formula-fed babies and less than 1 stool per week in breastfed babies. So we look again at the presence of red flags, which are again exactly the same as before, with some additional ones, such as no meconium for 24 or 48 hours, depends on where you want to put your cutoff. The more hours you take, the more likelihood that Hirschsprung's disease will be the case. You look for abdominal distension, vomiting, failure to thrive, bloody stools, the development of the baby in general. Of course, you look for anal and sacral abnormalities, and you look for any signs of other organic disease. If that's the case, you transfer the patient for further follow-up. If that's not the case, and if the child is breastfed and older than 2 weeks, if that's the case, you reassure, you educate the family and the child, saying that it's probably normal, but you organize a follow-up, because of course breastfeeding does not protect for Hirschsprung's disease, but that incidence will be low, so that's why you don't have to do anything but organize follow-up. If the baby is not breastfed but formula-fed, and you look if there is artificial feeding with or without solid food, then it's probably functional constipation. What you need to do then is reassure, educate the parents, verify the proper formula preparation, in fact, more or less the same as for the regurgitation. You first see if feeding weight technique is appropriate. If it's not appropriate, you adapt. If it's appropriate, you see if you go to the next step. So you adapt, you see if there is response or not, if there is partial or bad response. What you can do then is give lactulose if the baby is less than 6 months old, lactulose or polyethylene glycol, so macrogols if the baby is older than 6 months old. Consider switching to formula with a partial hydrolysate or extensive hydrolysate. Also, by preference, palm oil-free formula, because that's has also been shown to be effective in the treatment of constipation. And rectal treatment can be recommended if you need acute relief, but not as a chronic treatment. If there is a good response to your re-education or your additional treatment of lactulose, of polyethylene glycol did bring some benefit, then you maintain the therapy and you follow the child. If the response is bad, you transfer again to the specialty clinic. The next short topic is a few slides about additional information for the best formula choice. One comment regards prebiotics in a review paper that we just submitted. I think that there is a lot of reasons to add prebiotic oligosaccharides in infant formula because it's the third most important component in mother's milk. Addition of prebiotics to infant formula brings the microbiome of formula-fed infants closer to that of breastfed infants. Prebiotics have been shown to change the gut metabolic activity by decreasing the stool pH, increasing the short-chain fatty acid. They have a bifidogenic effect, so increase the number of bifidobacteria. And there is some evidence that these gastrointestinal changes induce a health benefit for the infant, although the benefit differs from study to study. Sometimes it's statistically significant, sometimes it's only a trend, but it's also very safe. There are no adverse events, and so it's something which is present in mother's milk, which has some benefit and which is very safe. So there is certainly reasons to add that to infant formula. So prebiotics are added to infant formula because they are present in mother's milk. And most studies suggest a trend for beneficial effects. That's a reason why you should add them to infant formula. Another addition for infant formula may be lutein fortified infant formula, because lutein is also something which is completely absent in cow's milk while it's present in breast milk, and it has been shown that you need it for development of your eye, of your potential to have a good visibility. So this is our data from a Russian study which showed that the addition of lutein in infant formula is safe, well tolerated, supported the anthropometric growth of the evaluated infants, and also showed some benefits on the visual accuracy of those infants. Another additional benefit is, I think, formula without palm oil, because palm oil-free formula has been shown to reduce regurgitation and also to be effective in the treatment of infant constipation. So this brings me to conclusion, where I would like to stress again that, of course, breastfeeding is the best way how to feed all infants, but that gastrointestinal symptoms are very frequent. They occur in half of the babies. What I try to show you is that you can bring reassurance by using dietary treatment. We did not discuss the prescription of any medication except maybe the use of polyglycol in constipated infants older than 6 months of age, but no other medication. By using dietary treatment, you have an effective tool which is very safe and which does not bring the risk of side effects for functional symptoms that medications will induce. And so you postpone drug treatment to when it's needed, to be prescribed by the specialist for those children in which dietary treatment did not help. And so, did I bring you something news? In fact, no, because Mr. Billings 150 years ago already knew that a good, reliable set of bowels is worth more to a man than any quantity of brains. Spasiba.
Thank you very much for your brilliant lecture. Уважаемые коллеги, у кого есть вопросы? У вас есть уникальная возможность задать какие-то вопросы профессору Ван ден Плассу. У нас стоят микрофоны. Пожалуйста, проходите к микрофонам, задавайте свои вопросы. Пока у нас... Да, пожалуйста, пожалуйста. Представляйтесь, пожалуйста, называйте город и вопросы задавайте.
Красноярск, Фурца. Уважаемый господин профессор, в вашей личной практике какие случаи были, когда ребенок находился на исключительно грудном вскармливании, и как редко был стул? Как редко? Из вашей личной практики.
Well, thank you. Bring up a very important point, and breastfed babies can have less than one stool a week, and that can be completely normal. So it's at that moment very important to try to reassure the mother. And so as long, I think the clue that you can use is as long as the baby is not suffering. And most of the time, those breastfed babies who only have one stool a week, they have no other symptom at all. And so then you have to try to reassure the mother. But so one stool a week is certainly something which happens regular.
Вы удовлетворены ответом или вы хотите подискутировать как-то? Не слышно, вы к микрофону тогда.
Дискутировать, конечно, можно долго, но, в общем-то, понятно, только единственное, в наших учебниках-то этого не прописано. Мы все пользуемся римской классификацией, и там уже запором считается, а действительно ведь стул мы видим на практике, может быть, и раз в неделю.
Yeah, but I think Rome criteria are very important for clinical studies because they help you to select patients with the same kind of problem. It's not because you do not really fall into the Rome criteria that you do not have the problem. You certainly can also criticize the Rome criteria because, for instance, for regurgitation, Rome criteria says 2 episodes of regurgitation a day. That's 40% of all the babies. So that's there the criteria is too low. For colic, criteria have also changed over time because now we speak for 1 week of crying time, and next year you will have the Rome 4 criteria, which will be a new version.
Спасибо. Но, положа руку на сердце, конечно, частота стула может быть разная у младенца на грудном вскармливании, но ведь вот увидеть, чтобы совершенно здоровый, ничего не волновало нас в его состоянии, и чтобы стул был раз в неделю, но мы же с таким не встречаемся. В общем-то, у таких детей находится масса поводов для беспокойства, и мы обнаруживаем, как правило, все-таки субстрат для такого редкого стула. Хотя, в общем, позиция, что в основном надо ориентироваться, естественно, на состояние здоровья младенца, это, в общем, совершенно правильно. Здесь не может быть жесткого. Скажите, пожалуйста, а что не переводите вы профессору? Я вас услышала отсюда по-русски, но профессор вас не слышит, соответственно, ваш перевод для него.
So for some reason, if you're speaking, I get it here, but I don't get the translation.
Вы услышали, пожалуйста, то, что я сказала? Вы сможете перевести?
So this.
She translates.
Yeah, but that mic is connected to. Yes. But now I did not get the question, of course, so for you.
Ну, собственно, это короткий комментарий относительно того, что ребенок с частотой стула раз в неделю на грудном вскармливании, как правило, все-таки имеет другие поводы для беспокойства. Хотя в целом мы вашу позицию о том, что надо прежде всего ориентироваться на здоровье ребенка, а не на какие-то формальные критерии, поддерживаем. Коллеги, пожалуйста, какие еще вопросы? Татьяна Эдуардовна, может быть, у вас есть какие-то вопросы или комментарии? А микрофон дайте, пожалуйста, профессор Боровик. Вот у нас пока вопрос тут возник.
Хотелось бы услышать по поводу смеси на основе камеди. Мы в Казахстане достаточно широко ее используем. Не прозвучало, просто не прозвучало или не используется?
Смеси на основе камеди. Я просто не слышу ваш перевод.
Yes, well, I did not discuss any specific thickened formula. I discussed anti-regurgitation formula. And I think what comes out from literature is that whether you thicken with bean gum or with cornstarch or with potato starch, it's not that much different. So the efficacy of the different kind of anti-regurgitation formulas is quite comparable on the clinical point of view. So the thickening agent used does not really matter. One difference might be that with bean gum thickened formula, the bean gum is also a prebiotic. So it's fermented in the colon and it causes in some babies crying and colic and gasiness because of that fermentation. But from the point of efficacy, no matter which thickening agent, it does not really make a difference.
Пожалуйста, микрофон передайте сюда вперед.
Спасибо большое, Иван. Очень интересная лекция. Мы с большим удовольствием ее прослушали. Я хочу сказать, что мы в своей повседневной жизни пользуемся вашими алгоритмами по назначению питания детей с подозрением на аллергию на грудном вскармливании, на искусственном вскармливании. Алгоритмы нам эти очень помогают. Мы их полностью разделяем и даже, в общем-то, широко используем. Что касается детей с функциональными нарушениями, здесь, конечно, гораздо сложнее. Мы в этом плане немножко отстаем, но тем не менее, в общем-то, тоже мы придерживаемся международных рекомендаций. Конечно, очень трудно отделить и очень важно функциональные нарушения пищеварения от органических. И вот действительно эта проблема большая, и ваша лекция, в общем-то, нам во многом разъяснила. И я хочу сказать, что в нашей стране действительно внедряются самые последние международные разработки, и мы не ориентируемся на свой собственный опыт, а действительно на те работы, которые вы представляете, которые созданы, написаны, обобщены. Вот мета-анализы, работа, которая создана на основе доказательной медицины, так что это очень приятно. И в нашей стране есть все возможности для того, чтобы помочь детям, и не только с функциональными, но и с органическими поражениями. Я хочу сказать, что у нас много продуктов, которые, в общем-то, помогают нам. У нас сейчас есть гидролизаты белка, их много, большое разнообразие. У нас есть аминокислотные смеси. У нас еще, к сожалению, нет смеси на основе гидролизата риса, но я думаю, мы, как он появится, этот продукт, мы тоже, в общем-то, найдем ему место. Так что те моменты, те ваши высказывания в плане использования смеси с пребиотиками, с пробиотиками, да, конечно, они влияют и на функциональное состояние кишечника, на микробиоту. Мы тоже это имеем в виду и тоже мы стараемся использовать. Так что большое вам спасибо. Я думаю, что мы получили очень много нового. Так что будем надеяться, что наши с вами контакты будут продолжаться, и вы еще не один раз к нам приедете, и позволите нам узнать действительно что-то новое. Спасибо.
Спасибо, Татьяна Эдуардовна. И тут вот еще один вопрос письменный поступил, как раз тоже относительно, с какого возраста можно назначать глубокий гидролизат рисовый, по вашему мнению?
Okay, well, I think that there is no lower age limit for extensive rice hydrolysates or partial rice hydrolysates because it's a therapeutic option in the treatment of the child that you suspect of having cow's milk allergy. So most of the time it will be in a child of at least 3-4 weeks old because you rarely diagnose cow's milk protein allergy before that age in exclusively formula-fed infants. But there is no lower age limit. There are nutritional studies done. It seems to be quite safe. Now, there is a lot of fuss going on in the internet about arsenicum and rice, but that has to do with rice milks, which have nothing to do with rice infant formula. So the rice infant formulas are, from that point of view, relatively safe.
Понятно, спасибо. Еще один письменный вопрос. Ваше мнение относительно следующего. Вы говорите, что пальмовое масло, входящее в смеси, не очень хорошо. Я не знаю, где слышали наши участники ваше это высказывание. Вот просто читаю записку. Это бывает причиной запоров. В некоторые смеси входит кокосовое масло. Эти смеси не вызывают запоров? Вот такой вопрос.
Well, what has been shown is that in an observational study that palm oil-free formula reduced regurgitation, and it's also known in different clinical trials that changing the palm oil to other oils, and where there is an SN2 position, for instance, that effectively treats constipation. So palm oil may be a cause of some functional gastrointestinal problems as well, and therefore palm oil-free formula may be of some additional benefit. The number of studies with palm oil-free formula is relatively too limited to put them really into the guidelines, but I would say it's the same like for pre and probiotics. There is some trend, there is some data that palm oil-free formula may be further beneficial, and it's certainly also very safe. So I would consider it as an additional benefit.
Понятно. Спасибо. Ирина Николаевна, вы как-то хотите что-то, может быть, спросить или прокомментировать?
Ну, сейчас, к счастью, мы с Иваном знакомы уже не первый раз, и он трижды в течение 2 лет приезжал к нам на наши образовательные семинары. Поэтому мы уже говорили ему о своей любви, о том, что мы очень давно используем рекомендации, считаем его действительно одним из самых величайших ученых европейских, и действительно, куда ни посмотри, то есть самые главные кардинальные проблемы — пищевая аллергия, срыгивание, антибиотикоассоциированная диарея — всегда его первая фамилия. Действительно есть, ну вот Иван говорил о том, что аллергии к смесям на основе аминокислот он видит редко. У нас почему-то в последнее время пошли пациенты, у которых типичные аллергические проявления, тяжелый атопический дерматит, детки первых месяцев жизни, но есть непереносимость как казеиновых гидролизатов, так и аминокислот. И вот для себя мы нашли у 20 пациентов нишу рисовый гидролизат рисового белка. И вот сейчас буквально мне одна мама, которая первая была пользователем этой смеси, прислала смс-ку, что во Франции в аптеке отказали в этой смеси, сказали, что ее больше не будут производить. Поэтому вот, может быть, это действительно проблема с мышьяком, о котором он сказал, или и где можно подобные смеси найти для таких небольшого числа детей, но у которых не помогает ничего.
Yes. Well, first of all, thank you for your comments. I think that what I said is that you cannot have cow's milk protein allergy with amino acid-based formula. That does not mean that you cannot have babies who still react allergic to amino acid-based formula, because they can react allergic, for instance, to the lipid content. So you're from one thing sure with amino acid-based formula, it's not cow's milk allergy, but children certainly can react to other components in that amino acid-based formula. The fact that it is purely chemical and does not touch anything from cow's milk makes it virtually impossible to have cow's milk allergy. It's true that if your rice hydrolysate does, for instance, have a different lipid component than your amino acid-based formula, your child may be well or better with your rice hydrolysate than with the amino acid-based formula. I think it's also a matter of time because the rice hydrolysates are cheaper than the extensive cow's milk-based hydrolysates. And for instance, in France, they all come from France. There are 2 partial hydrolysates and 1 extensive hydrolysate in the market. But in France, the rice hydrolysates do have 50% of the whole hydrolysate market. I really think that with rice infant formula, there is no safety issue at all. You should be careful to give to the infants, of course, infant formula, and not what is sometimes in some special shops, at least in our countries, commercialized as rice milk, which is in fact water in which some rice has been boiled and which is nutritionally absolutely not adapted to the children. So first of all, it needs to be infant formula to be nutritionally adequate.
Спасибо. Есть еще какие-то вопросы в зале? Тогда можно я еще спрошу вас, не могли бы вы прокомментировать такую тему, как перекрестная аллергия на белки козьего молока у тех, кто имеет аллергию к белкам коровьего молока? Видите ли вы какое-то изменение частоты таких случаев? И насколько правомочно указание на упаковках производителей козьего молока, ну, смеси, естественно, для детей, что это смеси для тех, у кого аллергия на белки коровьего молока?
Thank you. I think you bring up a very important point also. No, I do not think they have the right to say that. I think that, again, I understood that you have goat's milk infant formula here in Russia on the market. And for me, that's okay. That's a good alternative starter formula to the classic cow's milk-based infant formula, because it does not matter if you start from goat's milk, from sheep milk, from camel milk, from donkey milk, from cow's milk. Does not matter as long as your end product is something which is nutritionally adapted to the needs of infants. We just started to use cow's milk because there are a lot of cows and cows produce much more milk than goats. But if you look at the protein content, 80% of the proteins of goat's milk are the same as the proteins in cow's milk. So if you take 100 cow's milk allergic babies and you give them goat's milk, 80 will be allergic to the goat's milk. 20 will not be. But your 20% efficacy is much too low compared to the 95% efficacy of your extensive hydrolysate. So you cannot recommend something which has only an efficacy of 20%. So goat's milk, it's a good option as replacement for mother's milk, like we use cow's milk formula, but not in the treatment of cow's milk allergy.
На коробках в вашей стране, на упаковках к вот этим смесям на основе козьего молока есть подобного рода характеристики, что эти смеси рекомендуются для тех, у кого аллергия к белкам коровьего молока?
Well, we don't have goat's milk formula.
Вот вам и ответ на все вопросы. Спасибо. Коллеги, последние секунды, у вас есть возможность задать еще какие-то вопросы. Пожалуйста. Есть ли в зале у кого-то вопросы? Пожалуйста, дайте микрофон слушателю.
Уважаемый профессор, скажите, пожалуйста, используете ли вы пробиотики в лечении аллергии к белкам коровьего молока?
No. No, because I think if you look at the studies, about all the studies of probiotics in the treatment of cosmic protein allergy are negative. If you look at studies on the use of probiotics in the prevention of cosmic protein allergy, then half of the studies are positive, half of the studies are negative, and those studies which are positive are mainly those who started by giving the probiotic also to the mother during pregnancy, during the last month of life. Now I know there is one Italian study suggesting that you have a much better induction of tolerance if you add the namely Lactobacillus GG to an extensive hydrolysate. But you have to be aware that that is an open study, so the parents and the doctors knew very well which infant was receiving which formula. And therefore, I think that scientifically, that is a very weak study and that we cannot build recommendations on that. But it certainly opens a window for future research that probiotics may maybe induce a quicker achievement of tolerance, but that has to be confirmed in well-designed double-blind trials before you can recommend to do so. And I can tell you that what we did is we compared in Belgium in treatment 2 extensive hydrolysates, one with bifidobacteria and one with lactobacillus, and the induction of tolerance in the 2 groups, but they were both with probiotics, was exactly the same, and that was a double-blind study. So we did not know which child was receiving which formula, but that gives no answer if the addition of probiotics has an influence on the induction of tolerance, because in our study the 2 groups had a different probiotic.
Последние 2 вопроса, которые в письменном виде поступили. Первый относительно провокационной пробы. Каков объем провокационной пробы для детей на искусственном вскармливании матерей, кормящих грудью? Но, к сожалению, двойная слепая плацебо-контролируемая проба в нашей стране не сертифицирована. Мы, к сожалению, не имеем пока возможности ее применять. И второе, есть ли смысл переводить ребенка с антирефлюксной смеси на обычную, если срыгивания были купированы?
Thank you. So for the first one, all the guidelines contain recommendations on how to perform a challenge, and it's a gradual procedure starting with very small volumes, first a drop on the lip, and then increasing the volume every 15 minutes until the child gets his normal volume for a normal feeding what he needs. And so a challenge most of the time takes half a day. The second question for anti-regurgitation formula, I think that's the reason why I showed the natural evolution. I think that most of the babies go on with regurgitating up to the age of 6 months. After 6 months, there is a sharp decrease. So when you switch the child from stage 1 to stage 2 formula, you may switch from anti-regurgitation to a normal stage 2 formula. But you should be aware also that, okay, the child maybe not needs the anti-regurgitation formula longer, but there is no adverse event to that. So there is no harm if you keep it for longer than really needed.
Спасибо. Я думаю, что на этом мы закончим нашу сессию вопросов. И так мы слишком много спрашивали уважаемого профессора Ванденпласа. От вашего лица я хотела бы еще раз поблагодарить его за блестящую лекцию, а всем пожелать дальнейших успехов.
Спасибо. Thank you.
Thank you. Merci. Je voudrais discuter d'un autre thème.